Hello everybody and welcome to lecture 9 on cardiac output. The man you see kind of faded into the background right there in sort of an eerie way now that I'm looking at it. But in any case, this man is known as William Harvey, and he lived in around the 1600s, and he was a physician who has actually paved the way for our understanding of the systemic circulation, how blood moves through the body and how it's pumped by the heart. Okay, so let's talk about cardiac output now. Cardiac output, all right, is the volume ejected by the ventricles in 1 minute. So it's a volume over time measurement. It's a measurement of blood flow. The cardiac output, the formula for this is one that you guys need to remember. We'll be coming back to it quite often, is that heart rate times stroke volume equals the cardiac output. The heart rate, an average heart rate would be 75 beats per minute. The stroke volume is the volume that's ejected by the ventricles with every beat. So every time it contracts, what's the volume that it releases? And we actually went over stroke volume in the last lecture. And so an average stroke volume at rest is approximately 70 milliliters per beat. So if we actually use those two sort of average numbers there, these are of course numbers at rest, it would be 75 beats per minute times 70 mLs per beat. And what you'd end up with is you'd end up with about 5,250 milliliters, all right, per minute. And so that's approximately just a little over 5 liters every minute. And in fact, that's close to the average resting cardiac output. In fact, the range is typically 4 to 6 liters per minute at rest. And that's typically how we report a cardiac output, is liters per minute. Now, 4 to 6, the cardiac output at rest would vary depending on the person's size. Smaller the person, the smaller the cardiac output. As we'll learn in the cardiology course, we use another measure too in the clinic called the cardiac index, which actually helps to account for the person's size by including in the equation their total body surface area. So that gives us a better idea of how much or what their cardiac output should be given their size. Now, a way I like to put this, is that if, let's say, we are ejecting 5 liters per minute of blood out of both ventricles. Again, it would be the same amount, the same cardiac output in the right ventricle as the left ventricle. So 5 liters per minute going into the pulmonic circulation and 5 liters per minute going into the systemic circulation. So they're identical. Now, our average blood volume in total, all right, is about 5 liters. So therefore, you're ejecting your entire blood volume into your systemic circulation and back to your heart in 1 minute. And so I like the way this was put to me once, was that if you had a red blood cell that was leaving the left ventricle, it'll arrive back at the left ventricle in 1 minute. Okay. Now, the cardiac output is not just a fixed number. It does change depending on our state of physicality or our exercise level. So if we're resting, the resting cardiac output typically, again, is going to be 4, 5, or even 6 liters per minute. However, if we're exercising vigorously, then it can go up quite a bit. It has, it can go up, it can increase. And so for vigorous exercise, it could even go up to, say, 4 times our resting. So we can go from, say, 5 liters per minute up to 20 liters per minute. That's like, it's circulating your entire blood volume 4 times around in a minute. Now, if you have someone who's a very well-trained athlete, like a collegiate athlete or, say, an Olympian or something like that, they could even increase their cardiac output up to 7 times. So they could actually move their whole blood volume, let's say it was 5 liters per minute, or 5 liters, excuse me, they could actually increase their cardiac output upwards of 35 liters per minute. So again, that would also depend on, the condition of the person as well. Now, the reverse is also true. Cardiac output may not increase as much as a normal person's if somebody has some sort of underlying cardiac disorder. And in fact, there's a term we refer to called cardiac reserve. And this is the difference between a person's maximum and their resting cardiac output. Okay, so again, like an Olympic athlete, they can go from 5 liters up to 35 liters per minute. Okay. But you may have somebody with, say, some form of heart failure or something like that, and so their cardiac output at rest might be 5 liters, which we consider normal, let's say. and it may only go up to 6 liters per minute or 7 liters per minute. They're just not able to actually increase the cardiac output to match the demands that the body has. And so that would leave them with very little cardiac reserve, and so they of course would feel fatigued very easily. So with that thought in mind, the idea of cardiac output and injecting a certain volume of blood every minute, that cardiac output is actually designated by our bodies based on our tissues' metabolic needs, because what the blood is carrying is oxygen and nutrients and so on. So therefore, the cardiac output is actually set to match what our basal metabolic rate is in our bodies at rest. And so if you're to exercise, that metabolic rate goes up, the demand also goes up, so therefore the cardiac output has to go up to match that demand. So in somebody with, say, heart failure, if they try to exercise and increase the demand, the heart is unable to actually match that demand, and that's when they would start to feel fatigued and in some cases feel pain. They might even have symptoms of shortness of breath and feeling like they're going to pass out, or even chest pain. Now, that volume that's being injected every minute, all right, when that's injected into the systemic circulation, for example, what this cartoon is showing you, all right, is that here we have on the left side of the heart, so it's going to the left ventricle, is being injected into systemic circulation, that 5 liters that's being injected every minute is being divvied up by the different organs. There's a different demand for each organ. So if you take a look at that, this is sort of the percentage breakdown at rest of what tissues would require of that cardiac output. So like I said earlier, the cardiac output is set to match the demand of the body, and this percentage tells you what those tissues in particular demand from that cardiac output, how much of that cardiac output are they going to require. So for example, the brain requires 14% at rest here, 4% for the heart. All right, here's a number I'm going to be coming back to in the kidney lectures. 22% of that cardiac output goes to the kidneys. Inactive muscle here, so skeletal muscle, for example, would require about 15% at rest, and so on. So they all have different requirements, so therefore they get partitioned a little bit differently. Okay. However, these organs will all use up what they need, and then of course on the back end of that is the venous return, and that all comes together where all the veins coalesce to form the superior and inferior vena cava. And so that will return to the heart, and so that will be the 5 liters returning to the heart every minute. So that is how the cardiac outputs, as a whole, will leave as 5 liters from the left side of the heart, be divvied up amongst the organs based on its demand, and then of course all reshunted back to the venous system and returned to the heart to be reoxygenated into the pulmonary circulation and then back out again. So in terms of the factors that influence cardiac output, that's heart rate and stroke volume. So I'm going to go into heart rate first. So heart rate, clinically we can take a heart rate, right? We usually call it a pulse, and so a pulse is just a surge of pressure that's produced by the heart. So every time the heart's beating or it's in systole, right, it's contracting, it's ejecting a volume, and you can feel an upward pulse of the arteries. And so we can feel that. We can feel that in the radial artery. Okay, we can feel that in the carotids, and there's other pulses that we can find as long as they're close enough to the surface of the body. We can usually palpate it or feel it. And they're depending on the age of the person, those would vary and be within a normal range. So for example, infants have a heart rate of 120 beats per minute, sometimes even more, and that's okay. We wouldn't call the infant tachycardic in that state. That's normal for their development. A young adult, however, should be somewhere between 60 and 100, and really, more narrowly, the average is probably closer to around 75. So that's fairly typical. The heart rate again rises again in the elderly. So you tend to see higher heart rates in the elderly. So go closer to 80s, 90s. As they get a little bit older. Now, of course, heart rates are affected by the conditioning of the person as well. So you might have known that like some well-trained athletes, their heart rates could be as low as say, 60 beats per minute or 50, or in some cases like world-class athletes, you're looking at like 35 beats per minute, and they're asymptomatic, and their cardiac output is just fine actually. Now down here in this graph that you're seeing at the bottom, this is cardiac output all right, and heart rate. And so what it's showing you is that cardiac output is a function of the heart rate. So for example, if the heart rate goes up, so we're moving in this direction, if the heart rate goes up, the cardiac output also increases, right? Because again, they're directly correlated. So here you go, cardiac output equals the heart rate times the stroke volume. So we're just talking about the heart rate right now. We're ignoring stroke volume for now. All right, so if I'm saying the heart rate is going up, and I'm going to say, well, we'll keep stroke volume the same, then yes, the cardiac output will go up. And we can see that based on the equation, that it's directly related. Now, however, you'll notice at the top of the curve, it starts to flatten off and maybe even starts to dip a little bit. And the reason for this is, as we get to higher and higher heart rates, there is less filling time for the ventricles. In other words, the stroke volume starts to decrease because if it's beating so fast, it doesn't have enough time for blood to adequately fill those ventricles, and so the volume with which we're injecting with every beat becomes less and less. So the stroke volume starts to go down at very high heart rates. And so in that regard, because of that limitation, if the heart rate exceeds a certain number, and in fact that number is approximately about 180 beats per minute. I'm going to put that there, 180 beats per minute. So that's the heart rate. If we go greater than 180 beats per minute, that's usually too high of a heart rate for us to keep increasing the cardiac output. In fact, the cardiac output will start to plateau or even decrease at that point. And in fact, in some pathological conditions, the heart rate could exceed 200 beats per minute. It could be 250 or even 300 beats per minute, which is extremely fast. And in those cases, of course, the cardiac output would also decline, and the patient's tissues might suffer as well. So oftentimes, in conditions like that, our goal would be to bring that heart rate back down so that the stroke volume would improve and their cardiac output would improve and help to match the demand of the body. Now, pathologically, we have what we call tachycardia with the heart rate, right? So this is resting heart rate that's above 100 beats per minute. All right, so it stays above 100 beats even while they're at rest. And so that's considered tachycardia. It's not considered tachycardia if the patient or the person is exercising and their heart rate goes up. That's an expected response and a normal response. However, again, at rest, that's abnormal. And so certain things can trigger, a lot of things can trigger tachycardia, stress, anxiety, things that, as we study for exams and prep for these classes, we get kind of used to. Drugs, heart disease, fever. I think one of the biggest takeaways for tachycardia is that it can definitely be an indicator that a patient is sick. Okay, so it's something to look into. I mean, it could be something due directly by the heart, but there are many things that are not involving the heart at all, but the heart's responding to it. Okay, loss of blood or damage to the myocardium of the heart, right? So, yeah, people who have had, let's say, a heart attack or a hemorrhaging, you'd expect their heart rates to go up. Okay. Bradycardia. Now, bradycardia is the flip side. So this is where the heart rate is too low. Okay, and so it's less than 60 beats per minute. But as I said before in the previous slide, less than 60 beats per minute could be okay in, say, a young, healthy, well-trained athlete. We would expect the heart rates to be a little bit lower. But if they're symptomatic and their heart rates are below 60, we refer to that as bradycardia. And we could see this very typically when somebody is sleeping. The heart rates tend to go down. Low body temperatures, and again, endurance-trained athletes. So positive chronotropic agents, chronos meaning time, right? So positive chronotropic agents are agents or factors that will raise the heart rate. Okay. Negative chronotropic agents are factors that will lower the heart rate. So for example, to raise the heart rate, if our adrenaline is pumping, right, epinephrine is being released from the adrenal glands, that's acting on beta-1 receptors, that's going to get our heart rate up. That would be a positive chronotropic agent. Whereas a negative chronotropic agent would be something like acetylcholine acting on muscarinic receptors. And what that's going to do is it's going to slow the heart rate down. So again, whether it influences it up or down, we refer to that as positive or negative chronotropic agents. Okay, so a little bit further on the chronotropic effects of the autonomic nervous system. So first off, the autonomic nervous system doesn't initiate the heartbeats, and as you guys know, we reviewed that in the previous lecture, that comes from the SA node. and that there are specialized pacemaker cells that actually regulate the regular rhythm of the heart. However, the autonomic nervous system gives input to the heart and can help modulate its rhythm and also its contractile force. Now, there are cardiac centers located in our brain in a region called the reticular formation of the medulla oblongata. The medulla oblongata is in the brainstem, and what that does is that actually can initiate autonomic outputs and signal the heart to increase heart rate or decrease it. So the way that works is the brainstem would, if we want to stimulate or have what we call a cardiostimulatory effect on the heart to increase its heart rate, it's going to increase signaling to the sympathetic neurons located in the spinal cord, and then from the spinal cord they would reach the heart via the sympathetic trunk or the sympathetic chain that I reviewed in the previous lectures. At the same time, it could do the reverse. It could also send out cardioinhibitory signals, which would inhibit the sympathetics, and it would increase the parasympathetic signal, and that would happen via the cranial nerve 10 or what we call the vagus nerve. Now, the inputs to the cardiac centers in the medulla are really quite diverse. So in other words, you can think of anything that would increase your heart rate, and that's essentially coming from multiple regions of your brain, signaling the brainstem, telling the brainstem or the medulla oblongata to send the signal to the heart to increase the heart rate. So, for example, examples I would actually use in class if I were teaching in person is that, I might, as I'm talking, randomly call on one of the students, who I think is only partially paying attention. And then what ends up happening is they're quite alert suddenly and have, this rush of anxiety because they're not sure exactly what I was just talking about, and their heart rate goes up. Okay, so that can come from higher cortical regions. Okay, more of the emotional centers of the brain in the cortex, and that can actually talk to the medulla, and the medulla will then send the output to the heart to increase the heart rate. Okay, kind of a fight or flight almost in that regard, right? So it's triggered by something more emotional. So these higher brain centers, what I'm referring to them as, like cerebral cortex, the limbic system, which is part of the emotional controls, the hypothalamus, which helps to regulate some of our endocrine responses, and this helps to incorporate sensory and emotional stimuli that can all play a role in influencing the cardiac centers in our brainstem to either increase or decrease the heart rate, which is why sometimes patients with high anxiety, which raises their heart rate, any kind of biofeedback or things where they do meditation, where you're controlling the higher cortical regions and controlling your emotions and so on, can actually have an effect by lowering your heart rate and relaxing you. The medulla as well receives input from muscles, joints, arteries, as well as other parts of the brainstem. And so, for example, in your muscles and joints, you have what we call proprioceptors. Proprioception is your awareness of your body in space. The way we would test that in the clinic is, tell a person to close their eyes and touch their fingertips together. It's sort of their awareness. And there's a constant feedback from the medulla to these proprioceptors in the joints. And this helps them to kind of continue to regulate, so we can always know where our body is, so to speak. Now, how this relates to heart rate is that the heart rate can actually increase before the metabolic demand of muscle arises. In other words, let's say you're about to run a race, or you're about to exercise on a treadmill or something like that. Your body posture and your joints will actually change a little bit and send signals to the brain and say, all right, it's time to increase the heart rate. So your heart rate will actually start to go up before you even start to exercise, and this is sort of an anticipatory response. We also have something called a baroreceptor signal, and this helps to regulate autonomic output as well. And again, this is going to have to go through the brainstem, the medulla oblongata, but these are like peripheral receptors that can pick up on certain physical signals, send that back to the brainstem, and the brainstem can then adjust the heart rate accordingly. So, for example, these baroreceptors, as you can see in the cartoon over here, all right, they are located in the internal carotid arteries on either side, as well as the aortic arch. And in case you're forgetting your anatomy, the heart's down here somewhere, okay? So it's the heart down there. All right, the left ventricle would pump blood into this region here, into the ascending aorta. And so these receptors located in the arch and in the internal carotids, all right, what they'll do is they're actually pressure sensors, all right, baroreceptors, right, pressure sensors. And so what happens is if the blood pressure changes. If it goes up or it goes down, it changes the firing rate of those specialized cells. Those cells actually constitutively fire at like a baseline rate. And that firing is constantly signaling the medulla. So, for example, if blood pressure were to decrease, all right, the signal rate from the baroreceptors would drop. So remember, it's constantly firing. That signal would actually drop, so it would fire less often. And that would actually signal the cardiac center to increase the heart rate. And the mechanism of that we're going to go in the next lecture. But the idea is that drop in blood pressure signals the brain, says, okay, you got to increase the heart rate. And as we're going to learn in this lecture, an increase in heart rate is going to increase the cardiac output. An increase in cardiac output increases blood pressure. So we'll get to that relationship in a little bit. Now, if the blood pressure were to increase, the opposite happens. The signal rate actually rises, and then the cardiac centers decrease the heart rate. So, for example, the blood pressure is getting too high, it'll tell the brainstem, all right, you gotta, back off or inhibit those sympathetic inputs and inhibit a little bit more. And so the parasympathetics would increase their activity, bring that heart rate back down, which would decrease your cardiac output, and the blood pressure would come down. And in fact, because these baroreceptors are pressure sensitive, you could actually manipulate them yourself by palpating or pushing on or rubbing really the internal carotids, which is about the angle of the jaw. Okay, and if you put a little pressure there, now don't do this with both hands on either side, okay, because I don't want you guys to pass out, but if you were to put a little pressure on one side, the baroreceptor doesn't know if the pressure is coming internally from the blood vessel or if it's coming externally from you pushing on it. Either way, that increased pressure is going to cause it to decrease its signal rate and slow your heart rate down. It's a useful little trick if you're, if you ever have a high heart rate and you're at rest and you're a little anxious or whatnot. Sometimes doing a little what we call a carotid massage can help to lower that heart rate. And more on that, by the way, later on. Chemoreceptor signaling. So we have the pressure, which is the baroreceptor, but the chemoreceptors, they're going to be sensing certain chemicals in the blood. And their location is very similar to the baroreceptors. In fact, over here, you see it's in the aortic arch as well. Again, you can see the bifurcation of the carotids. And so they're referred to as the carotid bodies and the aortic bodies. And so these are actually detecting changes in certain compounds. So for example, it's sensitive to blood pH, so hydrogen ion levels, CO2, and oxygen levels. Now, for the most part, baroreceptors are far more sensitive within our normal physiologic ranges. The baroreceptors are far more sensitive for adjusting autonomic outputs to the heart. So with the carotid bodies, this is really going to be more important in respiratory control. So that's why I put here respiratory control. So when we talk about this in the respiratory lectures, you'll see how this helps with that. And that would make sense, again, because with breathing and exchange of CO2 and O2, right? Now, in cardiac control, all right, it will trigger an increase in the heart rate and cardiac output in cases where oxygen levels are low or CO2 is high, because they're usually inversed, right? So O2 is low, so we're hypoxic. CO2 is high, so we're hypercapnic. Or we have a low pH, meaning we're acidic, so to speak. Now, in those conditions, which they occur in certain pathological states, what might happen then is it could actually trigger an increase in heart rate and cardiac output and an increase in blood pressure, and the goal then would actually be to increase perfusion to some of the what we call sort of the body's major organs, the ones that are going to be needed to sustain living. So it would increase perfusion pressure to things like the brain, the heart, the lungs, and so on. Okay, things that we're going to get into later on in certain pathological states where, for example, let's say the blood pressure has dropped below 80 millimeters of mercury systolic, so it's very low. So now in this hypotensive patient, perfusion to the body might be compromised because we need a certain amount of pressure to actually perfuse our organs. So if the pressure is too low, we may not do that adequately. That's when you're going to see something like the carotid body and the aortic bodies take on a larger role in terms of controlling heart rate and cardiac output. Because in those cases, it's usually associated with a state of hypoxemia and high CO2 and so on. And this will trigger increased perfusion to the brain, the heart, and the lungs to help sustain and help keep the person alive. Okay, so interestingly, the heart rate of the heart, if we were to disconnect the autonomic nerves, the parasympathetics and the sympathetics, the heart rate would actually at rest would go from, let's say, 60 or 70 beats per minute at rest. It would go up to 100 beats per minute on average. That 100 beats per minute is actually the intrinsic firing rate of the SA node. That's what it would fire at. And since we don't usually sit at rest at 100 beats per minute, we're usually like 75 beats per minute or even 60 beats per minute. What that suggests is that that lower heart rate, that's lower than the intrinsic firing rate, is due to the fact that we have something called vagal tone. There's at rest an increase in parasympathetic input to the heart, which keeps the heart rate lower. So we refer to that as vagal tone. And so again, that's a steady background firing rate of the vagus nerve. All right, so that's the heart rate. So what I want to talk about now is the stroke volume. That's the second half of the cardiac output equation, which I'll just remind you again. Cardiac output equals heart rate times the stroke volume. So what we're talking about now is the stroke volume. This is the volume that's ejected every time the heart contracts. And to remind you guys, it's about, on average at rest, 70 mils per beat. So there's three variables that actually affect the stroke volume. So these three are the ones that have an impact on that stroke volume. Something called a preload, afterload, and then contractility. So just to give you an idea of what they really represent. So preload, if you look at the cartoon here where the blood is coming into the heart, the preload is really the volume we are starting with before the heart contracts. And if you recall from the last lecture, that volume right before the ventricles contract is actually known as the end diastolic volume. The end diastolic volume, remember at the very end of diastole of the ventricle, it's filled up with about 120 or 130 mLs of blood in each ventricle. That's considered the preload. That's what you're loading it up with. Okay, that's the volume. So if we increase or decrease, we're going to talk about how an increase or decrease in that end diastolic volume or that preload, how that's going to affect the stroke volume. The afterload. So the afterload, you can hear it looks like kind of a tourniquet on the aorta there. All right. What that really is just suggesting is that the afterload is basically any force that the heart has to overcome, any resistance that the heart has to overcome to eject that blood. Okay, so anything resisting it from being able to leave the heart. And then finally, contractility. Contractility is for a given volume. Okay, you have an intrinsic contractility of the hearts, with which the cardiac myocytes are built for. But we can increase their contractility. So we could have, let's say, 130 mLs in the ventricles, and the intrinsic muscle of the heart will contract that volume to a certain extent. Now, I can actually further increase the contractility by adding, let's say, more calcium or something like that inside the cell. And what happens is for the same 130 mils, I'm going to contract even harder. I'm going to squeeze it even harder. So I can increase the contractility of the heart itself. So let's talk about these three things. So we'll start with preload. So in stroke volume, the preload again is how much volume essentially we are filling up the ventricles with prior to its contracting. All right, so during diastole, what is that end diastolic volume? So what happens is you fill it up with blood, what occurs inside the heart is you increase the tension. So as you're increasing volume inside the ventricle, it's stretching it out. You can think of the chamber of the heart almost like a balloon, and as you start to fill it up with the balloon with water or the heart with blood, it starts to expand. It starts to stretch outward and actually increases the tension in the tissue of the heart itself, just like the tension in the balloon would start to increase as it fills up with volume. Okay, and so that's why we say tension slash volume. So as the volume increases, the tension would too. And so right before it's about to contract, so there's our end diastolic volume. So what's that total volume? So that's our preload. And here's what I put now. An increased preload causes an increased force of contraction. So in fact, the more volume we put inside the ventricle, the stronger the contraction you're going to get. Okay. In exercise, for example, when you exercise, your venous return of the blood that's being pumped through your systemic circulation, it's returning to the heart much faster and loading it up with a lot more volume. All right. And what that's doing is that larger volume coming from the venous system going through your superior and inferior vena cava, it's coming in at much rapid rates, filling it up to a greater extent. And so that's a larger preload or a larger end diastolic volume, and that's going to stretch out the muscle fibers of the heart, and you're actually going to get an improved contraction. You're going to have a larger stroke volume. This is actually referred to as the Frank-Starling law of the heart. This just means that the stroke volume is proportional to the end diastolic volume. In other words, if the end diastolic volume increases, the stroke volume increases. If the end diastolic volume decreases, the stroke volume decreases. Okay? Now this has to do with the intrinsic muscle fibers of the heart and how they behave. Okay? So when you're filling up the heart with more and more blood, you're actually causing the muscles to become stretched. Now this goes back to something we talked about in the skeletal muscle lecture. And what I talked about then was that there was an optimal range of contraction in skeletal muscle fibers, and this has to do with the actin and myosin overlap, right? If the skeletal muscles stretch too far apart, the actin and myosin can't interact with each other, and I don't get good contraction. Remember, cardiac myocytes also have striations; they also have myofibrils, so it's the same principle. The cardiac muscle, if it gets stretched too far, it doesn't contract well. If it's too scrunched together, it doesn't contract well. But the biggest difference between the skeletal and the cardiac is that in skeletal, we tend to rest in the optimum range. Okay, so even when the muscles relax, it's usually in the optimal contractile range. In the heart, that's not the case. If we were to empty all the volume out of the heart, it would continue to scrunch up, and those actin and myosins would overlap more and more. And this is okay because when we start to fill it with blood, it starts to expand, and the overlap becomes more and more and more optimal. And so we have the most optimal. Of course, if we were to overfill the heart and we were to expand it too much, then yes, it would no longer contract very well. And so this is actually what this chart or this graph is showing you. So if this is the muscle length, all right, and here's the muscle force that can be generated from that length. You have something called the passive or the diastolic force, and here's the active or the systolic force. We'll ignore the total force for now. So imagine I have a heart that the muscle is relaxed right now. It's not actively contracting. As it's filling up with blood, it's expanding, and we're getting better and better overlap of the actin and myosin. But we're also expanding all the other tissue in the heart as well, any of the collagen and the elastin that's in the extracellular space there. And you'll notice that as we fill it up, and by the way, this is our normal working range for our length for our heart. So let's say we're filling it up with volume. So I'm adding volume here. As I add that blood volume, I'm going to expand the heart. I'm going to expand those muscles. And the muscle length is going to increase as it's expanding. And you'll notice that during diastole, it continues to expand. You'll notice that the pressure or the force, all right, the force is somewhat increasing. And this is just in its passive tissue, which is building up tension right now. Okay. Now, let's say I filled it up at this point right about here. Okay, so now let's say I've filled up the heart. It started, let's say, at this point at point 0, and I've filled it to point X over here. So I've increased the muscle length by whatever amount that is. Okay, and then the heart, let's say, contracts because that's the end of diastole. It's going to contract, and it's going to contract at this force right here. So whatever this force happens to be, it's going to contract at that force. If it were allowed to fill up to, say, this point over here, all right, it would contract with this much force, and so on. And all this is saying is that as we fill it up with more volume and the muscle length stretches because of that volume increase, we're going to generate more and more force the more volume we have there, up into a point. Obviously, if we exceed the volumes out here, we're not getting good contractile force anymore because now the actin and myosin is stretched too far. Okay, and this cartoon is really just to illustrate the same point that I was just talking about in the previous slide, which ultimately the takeaway is this. The Starling mechanism just means that within a normal functioning heart, the more volume we add to the ventricle, the harder it's going to contract for that given volume simply because of the mechanics of the muscle. As it gets stretched, as those cardiac myocytes get stretched, they're going to align more and more optimally and actually provide us with better and better contraction because the myosin heads can interact with the actin more optimally and provide us with a better contraction. And so within our normal working range, the higher the volumes, the better the stroke volume because we're going to contract harder. In pathological states, we could overload the heart with too much volume and then stretch it too far, maybe in cases of, say, like heart failure or something like that. but those would be a pathological state. This is showing the same thing. It's just telling you that the length of the muscle prior to its contracting would matter. So in a relaxed state, as it's being stretched out, right? For example, if I tethered muscle to one end here and I tied a weight to the other end, this weight would be considered the preload, okay? Then I stimulate that muscle. I stimulate the muscle over here, and it's going to contract at that length, and it's going to generate just so much force. So for example, here's the length. If it stimulates, so this is the passive stretch of it. If I stimulate it, it's going to give me a contraction force of about there. If I stretch it a little bit further, the contractile force is going to be about here. And then lastly, the most optimal, if I stretch it to this point and I stimulate the muscle, I'm going to get the most optimal, or the most tension generated, the most force generated at that length. And if I go beyond that, I'm going to lose some of that tension simply because I'm overstretching the muscle. So in this case, they're using a weight to demonstrate that, but in the heart, obviously, the preload would be volume. Now the afterload. Okay, so stroke volume is affected by that preload. The more preload we have, the higher the end-diastolic volume, the better the stroke volume, the higher the stroke volume. In afterload, so afterload is the sum of all the forces that oppose the ejection of blood from the ventricle. All right, this is the resistance that has to be overcome by both the right and left ventricle in order to eject the blood. So you can see this as being the inverse relationship. The higher the afterload, or the higher the resistance inside the systemic circulation or inside the pulmonic circulation, so the greater that afterload, the lower the stroke volume is going to be. All right, because it's not able to get that out against the resistance as easily. So this is opposing the opening of those semilunar valves. So it's opposing the opening of the aortic and the pulmonic valves. This will limit the stroke volume. So the higher the afterload, the smaller the stroke volume. Simply because now the heart, when it's contracting, has to overcome that afterload first, and whatever energy is left for contracting, it'll eject finally. All right. Whereas if the afterload is very little, there's very little resistance to it. When it contracts, it can eject a much larger stroke volume. All right. Now, clinically, examples of an increased afterload would be hypertension. That's probably by far and away the most common cause of an increase in afterload on the heart. Okay. So if we have increased in blood pressure, so this is our arterial blood pressure. So somebody has hypertension, right? So instead of being like 120/80, maybe they're 150/90 or something like that. These are higher pressures in the arterial system that the left ventricle will have to overcome in order to eject a good stroke volume. Okay. Now the same thing goes for the right side of the heart. You can have pulmonary hypertension, and so that would be an increase in afterload on the right side of the heart. And another example of that, of increasing afterload, would be, let's say, instead of blood pressure, which is the most common, could be something what we call aortic stenosis or pulmonic stenosis. Basically where you have rigid valves. Those semilunar valves become calcified and rigid, and they don't really open as they're supposed to, and become a much narrower opening. So you're trying to basically squeeze a lot of blood through a much tinier space than what should normally be. And so this, of course, can increase the afterload, and this would ultimately reduce the stroke volume. And so here, this is going back to that lecture that I gave you guys previously, and you're looking at the pressure graph in the left ventricle, left ventricular pressure, and down here is the volume in the left ventricle. So again, the volume could be about 120 or 130 mils. This is isovolumetric contraction, and then there's ejection, and then you're down to your end systolic volume right here. All right, and before the ejection, you had the end diastolic volume right there. So usually the stroke volume is the difference between these two, the difference between the end diastolic volume and the end systolic volume. So if you started with 130 mils, and at the end you have 60 mils in your ventricle, so you ejected 70 mils. 70 mils would be your stroke volume. And so what this is saying is that in the graph that I showed you guys, is that at this point, at the end of isovolumetric contraction, right, as it's generating force but no volume is leaving, that typically coincides with a normal blood pressure around 80 millimeters of mercury. And once we've matched that, we start to exceed 80 millimeters of mercury, we're going to open up that aortic valve and eject blood into the arterial system. The arterial system, that's the pressure was 80, so that's why we had to generate that much force just to overcome it. That is the afterload. We have to overcome 80 millimeters of mercury, which is the afterload under normal conditions. Someone with hypertension, that pressure that we have to overcome may not be 80, it might be 100 or 110. So we have to generate even more force just to open up the aortic valve. And at that point, we've used so much energy to just open up the valve that we eject even less. And so the total volume that we eject could be less than 70 mils. Now, the last part of stroke volume is something we call contractility. And contractility refers to how hard the myocardium contracts for a given volume or for a given end diastolic volume or preload. All right, so again, it's kind of like if I have 130 mils here, I can squeeze it just so. But if I have 130 mils, I can really squeeze it hard or not so hard and so on. So there's gradations of it, and that's what we refer to as contractility. So the technical term for that is something we call positive inotropy. So inotropy is referring to how hard it's contracting. Chronotropy, which is what I talked about earlier, that's the timing. That's like the heart rate. Inotropy has to do with contraction. So a positive inotropic agent, or a medication or a hormone or something like that, will increase the contractility of the heart. So, for example, electrolytes. If you have high levels of calcium, that could actually increase the contractility of the heart because there's more calcium available for contractions and cross-bridge formations and so on. The sympathetic stimulation, release of epinephrine, would increase inotropy contractility. So in this case, the autonomic nervous system, the sympathetic nervous system, increases heart rate and it increases contractility. Negative inotropic agents would be parasympathetic. So not only do they slow the heart rate down, but they also can reduce contractility. States of hypocalcemia, not enough calcium to allow good cross-bridge cycling. So in summary, of those three features, we have an increase in preload or contractility will increase the stroke volume. Increases in afterload would decrease the stroke volume. And so on this graph, this is actually a graph that you guys will find in your notes. We're looking at stroke volume as a function of end diastolic volume. So here at X is our normal. So you know what? I'm going to move to the next slide and let's draw some examples. Okay. So what you see here, this is our stroke volume again, and here's our end diastolic volume, also known as a preload. And so let's say our normal, all right, so this is our control state, or our normal is the middle line, that middle line. And so X is going to mark our average resting condition. So let's say that stroke volume is approximately 70 mLs. Let's use the same numbers we've been working with, 70 mLs. Okay, and the end diastolic volume that was associated with, so right here would be, let's say, about 130 mLs. All right, that's an ml. Sorry about my handwriting. So the preload there is 130 mLs, and then the stroke volume is 70 mLs. That's a typical stroke volume for that given preload under what we call normal contractile state, just the normal inherent contractility of the muscle tissue. Now let's say we want to increase the contractility. So we're stimulating it with the sympathetic nervous system. So we're increasing contractility. If we increase contractility, we are switching to this the line up here. All right, that's an increase in contractility. So now for the same preload, right? If it's still 130 mLs, I draw my new line right here. You notice that that's associated with a higher stroke volume. Okay, and the same thing goes for if I have decreased contractility. So let's say it's parasympathetic, I'm going to shift lines downward. So I'm going to move this direction, okay, at the new point here. So for 130 mLs, if my contractility is decreased, you'll notice here that my stroke volume is now less than 70 mils. And that would make sense, all right? That logically makes sense, but I'm just kind of going through this to make sure you understand how to apply it to this graph. So I want to remove some of this for a second. Now, in addition, there were some other parameters that affected stroke volume. So that was an example of how contractility does. Let's say I'm under normal conditions, I'm not increasing or decreasing contractility, but I want to increase my end diastolic volume to say, let's call this 200 mLs. All it's going to do is it's going to move me up the normal line here because I'm not changing contractility at all. And that, because of the slope of this line, is going to give me a higher stroke volume. So that has to do with the preload, right? So if I increase the preload, my stroke volume goes up. So this is really just showing you that this direction is an increase in preload. If I go this direction, I'm having a decrease in the preload, and so therefore my stroke volume would go down. And that has to do with the Starling mechanism and how much we stretch those muscle fibers. All right. Now let's try another example. So there's one other parameter that we haven't talked about. So we talked about contractility, preload, and now so afterload. So I'm going to put here at the top line, I'm going to put slash decreased afterload. So decreased AL or decreased afterload. Over here I'm going to put slash increased afterload. That looks like an H, I'm sorry. All right, increased afterload. So in other words, let's imagine we're starting at 130 mLs. That's our preload. And for that same preload, let's say I'm not changing the contractility. All right, so I have just my intrinsic contractility. I'm starting with 130 mLs, so I'm at this point right here. But then I increase the afterload. All right, I increase the afterload. So if I increase the afterload, my new working point is going to be down here. It shifts the curve downward, because that increased afterload means it's an increased resistance that I have to overcome, and it's going to reduce my stroke volume. That's going to reduce my stroke volume. On the other hand, if I reduce the afterload, it shifts me in the other direction. It shifts me to the top curve. And so my stroke volume will increase because I don't have to overcome as much resistance to that. So the only way I shift off the normal curve is, again, I would shift upward if there's an increase in contractility or a decrease in afterload. I would shift downward if there's a decrease in contractility or an increase in afterload. And finally, if there's afterload and contractility are remaining normal, then any change in my volume would just maybe be reflected as changes on the normal curve there. And so you can try in the notes. There's a bunch of examples there that you guys can practice with, and we can always review that more in the live sessions. But that's going to give you combinations of things where it's saying, well, what if I had an increase in preload and a decrease in afterload and an increase in contractility? And so there's kind of multiple ways to kind of play with this to where you think the graph is going to be. And just so you're clear, this increase or this, let's say this increase or the moving up of the curve here or the decrease in the curve here, the moving down of the curve, that's not a fixed point. There's gradations with how much it goes down or up depending on how much the afterload increases or decreases or how much the contractility goes up or down. So those aren't absolute fixes. It's just, it's anywhere in between there. Okay, so clinically, when we're working with the heart, we have many different things we have to measure to make sure the heart is acting or in a healthy manner or appropriately for the given conditions. And so there's things that we're going to look at, right? So one of the things we're going to measure is a cardiac output. In cardiology, we'll talk about the different techniques that we use to measure a person's cardiac output. But one example would be taking an echocardiography, right? So you're basically taking a sonogram, and you can actually make measurements like a cardiac output, and it can be fairly accurate. An ejection fraction. Ejection fraction we talked about actually in the previous lecture. That's a very useful number to know, which is basically it's taking the ratio of the stroke volume over the end diastolic volume. I went over that with you guys last time, and I told you if our stroke volume was 70 mLs and the end diastolic volume was 130, that the ejection fraction was about 54%. And our normal is somewhere between 50 and 65%. It tells us how effectively the heart's able to contract for the volume that's there. Okay, so for example, if somebody's stroke volume were to go down and the end diastolic volume were to go up, for example, you'd see the ejection fraction would come down. So anything less than 50% could actually be pathologic. Okay, so the third one which you're seeing is something we can use called a pulmonary capillary wedge pressure. And so just like the name suggests, we're actually taking a catheter, and this is actually what the cartoon is showing you over here. There's a catheter in black, you can see, and we're actually inserting that through the venous system into the right atrium, and we can actually snake that into the right ventricle and into the capillaries, and we wedge it, literally wedge it into the pulmonary circulation capillaries there. Inflate a little balloon so it props it up against the wall, and what that does is that creates a continuous column of blood towards the left atrium. The capillaries are too small for us to actually get the catheter all the way through into the left atrium, And so what ends up happening is any pressure changes that occur in the left atrium, that gets transmitted backwards, that can be picked up through this column of fluid at the tip of the catheter there, the pulmonary capillary wedge pressure can be recorded now. And so we can indirectly see what the left atrial pressures look like. And of course, if the left atrium is open to the left ventricle as it would be in diastole, the pressures in the left atrium and the left ventricle would be the same, and so we could indirectly get left ventricular diastolic pressures as well. And so it gives us an idea of how much pressure is building up maybe in the left atrium and left ventricle. These can be really useful, especially in cases where you have heart failure type patients or patients in an ICU where you really need to keep an eye on their functionality. And we'll get more into the details of sort of the specifics of that later on. Rate of pressure change, this is where you can use left ventricular pressure graphs that you're recording of the patient and actually look at the rate of changes of those different slopes, so the isovolumetric slopes, whether it's isovolumetric contraction or relaxation, that can give you information as to the force of contraction that's actually being generated. And then lastly, the pressure volume loop. So I'm going to spend some time now and talk about that. So in the pressure volume loops, just like it sounds, this is looking at volume in the left ventricle, and we're talking about pressures in millimeters of mercury, and we're specifically looking at the left ventricle, all right? And what this is going to do is actually shows us, it demonstrates the effect of preload, afterload, and contractility, and it can kind of take us through the cardiac cycle. So I really like these loops. So let's go through it. So let's say our volume, so we'll start at 50 mLs. Now that's the volume inside the left ventricle. All right, and the left ventricle is relaxed now. We're going to be in diastole. And so you can see the red arrows in this direction here as it points to B. So what's happening is the left ventricle is filling up with blood. So that's why you're seeing the volume increasing in this direction all the way to this point right here, point B. All right, and you see the pressures. The pressures on our y-axis there. You see the pressure goes up a little bit. And that's just as the left ventricle fills up with blood, it's going to create a little bit of tension in the walls there, and that's going to generate a little bit of pressure, okay, inside the chamber. So this is, again, diastole as it fills up to point B, at which point we're going to go into systole, right? At the end of diastole there, as the ventricles start to contract, the first thing that's going to happen is the mitral valve is going to close. It's going to slam shut to prevent anything from moving back into the atrium. And now we're in isovolumetric contraction, which you can see right here. What we're doing now is we're generating more and more pressure, right? Because we're squeezing that volume of blood. That volume of blood isn't going anywhere yet. That's why it's isovolumetric. Once we reach the aortic pressure, which under normal circumstances is about 80 millimeters of mercury, okay, the aortic valve is going to open. This is also our afterload. Remember, this is what I talked about in terms of our afterload. This is the pressure we have to overcome in order to eject our stroke volume. So the height of this, at 80 millimeters of mercury here, this right here is representative of our afterload. So the height represents that afterload. Then once we're ejecting, you notice the volume is starting to go down because we're moving in this direction, right? We're moving back towards the left. So the volume is being ejected. So you're starting to see a shift now. The volume is being ejected. The pressure is still going up because we're still squeezing that volume, but now we're ejecting it. So that's why we call it the period of ejection. And then you'll notice that the pressure starts to decrease as the muscle starts to relax a little bit, the ventricle starts to relax and go into early diastole. And at that point, the aortic valve is going to close because that's going to be the backflow coming from the aorta trying to get back to the ventricle. The aortic valve is going to close and prevent that. And the pressure continues to drop in our left ventricle, and this is our isovolumetric relaxation. And it drops low enough until the mitral valve opens up again. Now, under normal resting conditions, we do not eject the entire volume that we started with. So we had about 100, in this example, about 120 mLs was our end diastolic volume. That was over here. End diastolic volume was about 120. So that's our preload. All right, so our end diastolic volume about 120, that's our preload. So we're going to get a certain stroke volume for that preload. Our afterload was the pressure we had to generate to actually eject the blood, okay? And the amount we contract, in this case, that would be our contractility. So that's showing us how much we could actually eject for that given preload. Now, again, as we come back to our end, the end of our contraction cycle, we are at the end of our isovolumetric relaxation, we have what we call our end systolic volume. We still have about 50 mLs left in the ventricle. So that's our end systolic volume. So the difference between our end diastolic volume and our end systolic volume is the stroke volume, which is what you see here in the center. So the stroke volume is the difference is the width of that box. It's the width of the pressure volume loop. All right. So that's the stroke volume. So this graph is actually very useful to look at the cardiac cycle and the different valves that close and how the pressures change. And it shows us pretty much all the characteristics that affect stroke volume. In this graph, I've actually drawn out the pressure and the volume. So you see over here, pressure on the y-axis and then volume on the x-axis over here. And so I'm going to draw out the pressure volume loop to review some of the important points of this again. So let's just say I'm going to start here on the volume at about 60 mLs, which would be my end systolic volume. My end systolic volume, or the volume that I have in my ventricle at the start of diastole, just after it's contracted. And you'll notice I've drawn a curve here. All right, and we're going to follow this curve as we fill up with volume to about 130 mLs. And 130 mLs will represent the end diastolic volume, or otherwise known as the preload. Preload. This curve that it's following is actually called a passive curve. And what you'll notice about it is that this passive curve, the pressure goes up as the volume increases inside the ventricle. So this is the passive expansion of the cardiac myocytes and the connective tissue that surrounds it. And so as it starts to fill up, some of the pressure will increase as we start to try to stretch the heart out a little bit, and that's why you see a gradual increase there. There's no contraction occurring right now, it's simply passively filling up, but there will be a little bit of tension, a little bit of pressure developing inside that chamber as we do so. Now at this point, at the very end of diastole, we're going to undergo a contraction, and as we contract, we're going to close the mitral valve, because we're specifically talking about the left ventricle right now. And that pressure is going to go up, and it's going to go straight up because we're not changing any volume at this point. We're going to go to this point right here. So under normal circumstances, our lower end of our blood pressure is about 80 millimeters of mercury in our aorta. And so therefore, it's going to take about 80 or a little bit more than 80 millimeters of mercury to open up that aortic valve. So this is isovolumetric contraction, so there's no change in volume. And then we're going to eject at this point. Once we go above 80 millimeters of mercury, there's going to be an ejection of volume, so the pressure continues to go up and then comes down slightly. So what's happening here is we're actually ejecting volumes. That's why the volume is getting less. We went from 130 down to 60. So we were actually ejecting that volume. We're losing that volume from the ventricle. The pressure continues to go up because the ventricles continue to squeeze. Even though it's already opened up the aortic valve, it has to continue to generate pressure to eject that volume. And so it peaks at about 120, where you start to get more of the relaxation. It starts to actually not contract with as much force until we reach this point over here, this last point, which hits this other curve. Now this other curve here, this top curve, is called an active curve. What the active curve represents is it represents the contractile force, or the contractile pressure that's generated by the ventricle, by the muscular tissue. Okay, so just like I spoke about earlier, when we fill up the heart to a certain degree, that's going to stretch out the cardiac myocytes. That's going to take the sarcomeres and put them into better alignment to get a better contraction. And that's the Starling mechanism. So the way we do that normally in the heart is we fill it up with more volume. It's going to stretch it out and give us a better contraction. So here we filled it up about 130 mils. It started to contract and it generated as much force as it has to overcome 80 millimeters of mercury. It went up to 120. And then it ceases to continue to eject at that point on our active curve, because the volume that's now in the ventricle and in the pressure that the ventricle can generate, it cannot go any further. It cannot inject any more blood into the aorta. And so now at that point, the pressure is going to decline, and it declines, and we don't lose or gain any volume at that point. So that's an isovolumetric relaxation. And so that's actually, that volume pressure loop is showing us the cardiac cycle. And it's also giving us the information about stroke volume, how stroke volume is impacted here. So for example, we know that we started with 60 and we ended with, we started at end diastolic volume was 130, excuse me, and we ended up with 60 as our end systolic volume. So the difference between those two is 70 mLs. So under our normal conditions, we've ejected about 70 mLs. So that's our stroke volume there. And as you know, there's three factors that affect stroke volume. That's preload, afterload, and contractility. So what I want to draw for you right now is I want to change one of those factors at a time while leaving the other two constant. So for example, right now I want to draw what increasing the preload would look like on this pressure volume loop. But I'm not going to change afterload or contractility at this time. So if I increase preload, I'm going to say we'll start with 60 as our systolic volume again. And as it increases, I'm not going to stop at 130. I'm going to draw it in green over here. I'm going to go to this point over here. And we'll call that 150 mLs, let's say. So there's an increase in volume now. It's 150 as opposed to 130. We're going to go through the same process, isovolumetric contraction up to about 80. And then there's going to be an ejection. And the ejection is going to go back to the exact same point along our active curve. What happened, what you're seeing here is the Frank-Starling mechanism in play. By increasing the volume, I've stretched out the cardiac myocytes to a greater extent, and I've actually made the actin and myosin overlap more optimal. And so for that greater volume, it will give me a greater contraction, and I'll eject more volume for that. So the width of my new the width of my new pressure volume loop has increased. So now it's 150 end diastolic minus the 60 end systolic. So you can see that that is now an increase in my stroke volume by increasing my preload. Now let's say, I'm going to erase some of this first. Let's say I have now going to have an increase in afterload. And I'm going to keep preload and I'm going to keep contractility the same or constant. So if my preload is the same, I'm going to use blue now and I'll use the X's. So here's my start point. Okay, so my end diastolic volume is the same. But with afterload is the pressure that the ventricle has to overcome in order to eject volume. So normally it has to overcome 80 millimeters of mercury pressure in order to start to eject volume. But if I've increased the afterload, then the height, this height, I'm going to draw it out right now, the height is going to go higher than, I'm just going to pick a random point here, but it's going to go higher than previously because now the pressure in the aorta is much greater, maybe because the person's hypertensive. And so they may have to overcome 90 or even 100 millimeters of mercury before that aortic valve will open. And so that's, the height of that line actually represents the afterload on our graph. Once we've reached the afterload, what we actually eject is going to look like this. We're going to get a little bit of a peak maybe, and then it's going to stop at this point along our active line. So we end up with an overall narrower box, all right, a narrower pressure volume graph. So the stroke volume, the width of this, so the end diastolic is 130, but the end systolic might be 70 or 80 at this point. So the stroke volume is decreased because we had to use more energy to overcome the afterload, and so it affected our stroke volume by decreasing it. Okay. Now the last curve. That's going to show you. I'm going to erase some of this so that we see more clearly. Now this active curve, the one that I drew for you is right here. Okay, that active curve represents our contractility essentially. Okay, how much we're contracting. So at control levels, that just means the intrinsic contractility of the muscle. There's no influence on it. But let's say I increase the contractility. So epinephrine is binding to it, causing it to contract more. There's more calcium present, and so on. So by increasing contractility, in this example, I'm going to leave preload the same and afterload the same. I'm just going to change the contractility. So to represent that, what I'm going to do is draw another active line, and it's going to have a steeper slope. Okay? So if I go back to our original preload, which is 130, we'll start there. So my original preload is at 130. And it starts to contract, so we're minus the volumetric contraction. The afterload is the same, only has to overcome 80 in this case. All right. Once it overcomes that pressure, it can start to eject. But now I'm contracting harder for that same volume. And so here's what happens. As it ejects over to the point on the line over here, on the new contractile line. And then I draw my isovolumetric relaxation down to here. So what happened in this case? Well, in this case, I've actually increased my contractility while keeping afterload and preload the same. And so now I have a greater width of my pressure volume box. So my stroke volume is increased. So that's 130 minus, say, 50 or 40 or whatever it happens to be. So the stroke volume has gone up with an increase in contractility, as well as the end systolic volume has actually decreased because I've ejected more of my end diastolic volume. Now, I'm not going to draw it in here, but when we talk in cardiology, in heart failure, that contractile line, the slope would actually be reduced. So a reduction of the slope would actually be a weakening of the contractile ability. And so in cases of heart failure, since it can't contract as hard, it doesn't have as good a stroke volume, and more volume is left behind in the heart. So the end systolic volume can start to rise. Now, of course, you can have combinations of these three. I've shown them to you individually while keeping the others stable. But you can have any kind of increase in, say, end diastolic volume with an increase in afterload and decrease in contractility and so on. So there's complexities to this, but if you understand the basics of how one variable can work, then you can work within those parameters. All right, so then of course the other piece of this puzzle is we have the cardiac output, which is the volume over time being ejected, which is reliant on heart rate and stroke volume. Then there's the venous return, and the venous return, of course, is, as we eject that volume out into the systemic circulation, then we have to have the return of that blood, that 5 liters per minute, is going to be returned via the venous system. And so this is, the volume that's returning to the heart per minute, which under normal resting conditions should be the same as the cardiac output. And what this is showing, this is from your notes, is that an increase in venous return, all right, is going to increase the ventricular volume at the end of diastole. So let's say we have, for whatever reason, an increase in our venous return. Maybe we're exercising or something like that. That increase in volume is going to increase our stroke volume, right? Because we're increasing the preload. That's going to increase our cardiac output. So for whatever reason, our venous return goes up, we will have an increase in our cardiac output subsequently because of the Starling mechanism due to the increased preload. So factors that influence the venous return. First off, it's a pressure gradient. All right, all blood flows down its pressure gradient. So it goes from high pressure to low pressure. There has to be a pressure difference for any blood flow to occur at all. In the venous system, the pressure gradient is kind of small, but there has to be one. So for example, it could be from 10 millimeters of mercury at the venule end of a capillary and be 1 to 0 millimeters of mercury in the right atrium where the venous blood is returning. So that's our gradient, is from 10 to 1 millimeters of mercury, for example. So that's actually the most important, which is why I put that in bold there. So without a gradient, there's no flow of blood. Venoconstriction, venodilation. Veins do have some muscle, so they can contract a little bit. When they contract, that can actually propel blood back towards the heart. So that's a mechanism that can be used. Venodilation would be the opposite of relaxes, which makes it more compliant and it can hold on to more blood, and it would be less likely to return to the heart then. Arterial resistance. Arterial resistance. So the arterioles are the arteries that come right before the capillaries. If they're constricted, for example, so the resistance has gone up, they're constricted. That's not going to let a lot of blood going into the capillaries, which means that not a lot of blood from the capillaries is going into the veins. So that can actually reduce venous return. On the other hand, if the arterioles are dilated, opened up, that'll allow more blood into the capillaries and thus more into the venous system, so venous return can go up. As well, we also have a skeletal muscle pump, which you can see in the cartoon over here, where a lot of our veins are situated in such a fashion between muscles so that when the muscles are contracted, when we're moving around, it's actually going to compress the veins. And the veins have these one-way valves, which you can see in there. And as that helps to milk the blood against gravity, because it's not a high pressure system and the walls of the veins are not as tight, this actually helps to move and milk blood back towards the heart. All right, and then the one-way valves will prevent it from going backwards. Okay, especially against gravity, we don't want it pooling into our legs. Then there's the respiratory pump. So we're going to go more into this in the respiratory lectures, but just in short, if when we breathe in and our thorax expands and our lung expands, that actually decreases the pressure in our thorax. It becomes somewhat negative initially. So that negative pressure draws air into our lungs. That negative pressure that's drawing air into our lungs can also draw blood from other compartments of our body into the thorax. So it actually helps to move blood into the thorax because it's going to create more of a gradient for blood to flow. And then finally, we get a little effect from suction of the ventricular relaxation. So you can imagine when it contracts, as it pulls open. When it pulls open, it creates a slight vacuum that can draw a little blood into it. Again, because it's kind of in a closed loop with the heart and all the vessels. So when it contracts and then opens, when it's opening like that, it's almost like it's drawing, creating a slight vacuum, pulling that blood in. Okay, so quick recap. Cardiac output is equal to the heart rate times the stroke volume. So those are the two factors that influence cardiac output. An average cardiac output is about 5 liters per minute. And so that's the volume of blood that would be ejected from the left ventricle or right ventricle in a minute. And then it goes through the circulation, and we have what we call venous return, which I spoke about on the previous slide. The volume over time in venous return back to the heart in a state of equilibrium would equal whatever the cardiac output is. So if the heart is ejecting 5 liters per minute, the venous return to the heart will also be 5 liters per minute in equilibrium. Now, I wanted to talk a little bit more about blood flow because there's many factors that can influence the flow of blood as it goes through the vascular system. Okay, so looking at this graph, over here we have pressure on this axis, and we can see on the y-axis is actually a breakdown of the circulatory system. So it starts with systemic, so you see the aorta, large arteries, small arteries, arterioles, capillaries, venules, small and large veins, and then the vena cava, and then finally back to the right atrium. And the first thing I want you to notice, there's the pressure. Notice that the pressures in the arterial system are much higher than the venous system. In fact, if you follow the trend, the pressures in the arterial system, they fluctuate, okay, they're pulsatile, anywhere from a max of 120 to as low as 80 in normal conditions. And then that pulsatility goes away by the time you reach the capillaries, and you'll notice the pressure is also dropping, and then the pressure drops still further in the veins, close to 0. And by the time you get to the right atrium, the pressure is actually 0. So there's a pressure difference from the arterial side to the venule side, or to the venous side. And this is important because blood doesn't flow without a gradient. Blood flows from high pressure to low pressure. All right, so there has to be a pressure difference for blood to flow. And since the pressure difference is from the arterial side to the venous side, blood flows towards the veins and back to the right side of the heart. And so that pressure difference has to be maintained, otherwise we lose the ability to perfuse our organs and so on. Okay, now what you're seeing is that that pressure difference drops pretty substantially at the arterial level. So the arterioles, remember, they're the most abundant arteries. They're the ones that can actually regulate blood flow the most. And so they actually offer, and I'm going to explain this a little bit further later, they're going to offer the most resistance. Now, resistance when it comes to blood flow inhibits blood flow. The more resistance you have, the less blood can flow. And so in this case, this increased resistance in the arteriole actually causes a pressure drop. And so you see that across the arterioles, and then it goes through the capillaries and so on. So the formula for this, the formula for the blood flow and the factors that affect it, all right, this actually comes from Ohm's law, where flow, we're talking about blood flow, is equal to the delta P over the R. Flow oftentimes is written in textbooks as Q, the variable Q, but flow is referring to blood flow, volume over time, which is similar to what we just talked about with cardiac output. Delta P, delta means a change in, and P means a pressure. In other words, there has to be a difference in pressure. Just like we have a difference in pressure from the arterial to the venous side here, there has to be a delta P, a difference. Okay. In other words, if the delta P, in this case, let's say it was 100 on the arterial side and close to 0 over here on by the right atrium, then your delta P is 100 minus 0, or your delta P is 100 millimeters of mercury. That's the difference. And that's fairly standard for us under normal physiologic conditions. Okay. The R stands for resistance, and there's many factors that go into resistance, which I will get to in the later slides. But resistance inhibits blood flow. And so if resistance were to increase, the effect would be to reduce flow because they're inversely related. So if resistance goes down, flow goes up. And there's multiple things that can affect that resistance, and so we'll get into that. And so this is telling you that flow is directly related to a pressure difference and inversely related to the resistance. And that's actually something we can see here in this graph. Okay, so we'll come back to this, but this is Ohm's formula for blood flow. The last thing I want to mention on this slide before I move on is you'll see that the pressure in the arterial system is pulsatile. It peaks at 120 and it drops to about 80 under normal conditions. And it's pulsatile because of ventricular systole and diastole. When the ventricle is in systole and it's contracting, it's ejecting blood into the aorta and exerting more pressure, and that pressure can reach up to about 120 millimeters of mercury. When the ventricle relaxes, the aortic valve closes, and the aorta slowly starts to recoil, and the pressure starts to drop. So in other words, as the blood gets ejected, it stretches it, and then it recoils slowly. And so during the stretching period, that's when we feel the arteries are pulsing upward. That's about 120 millimeters of mercury. The low number, 80, is when the vessels are actually recoiling. And this is because these arteries have a lot of elastin, which allows it to stretch and recoil. And this is an important feature of the arteries because they're under high pressure. So what happens is when we inject the blood into the artery, it will actually stretch, which will absorb some of that energy, so the pressures won't go too high. And then when the ventricle relaxes, we don't want blood flow to cease every time the ventricle relaxes. So when the ventricle relaxes, there's a slow recoil that occurs, which actually squeezes the blood and continues to push it forward through the systemic circulation. In this way, we continue to have blood flow even though the ventricle is in a relaxed state right now. Otherwise, if we didn't have this sort of recoiling action of the arteries, what would happen is every time the ventricle ejects, we'd have blood flow, and every time it relaxed, blood flow would cease. So the fact that they can recoil, stretch and recoil, enables us to actually continue to have flow while the ventricle is in a relaxed or a diastolic state. And so it'll recoil and relax back to about 80 before the next contraction occurs. And so the 120 is referred to as a systolic number because that's when the ventricles are in systole. And the 80 is referred to as the diastolic number because that's when the ventricle is relaxed or in diastole. Okay, so this slide is kind of reiterating some of the things I mentioned in earlier slides with cardiac output, because cardiac output is a volume per time. Blood flow is the same thing as like a cardiac output. It's volume over time. And so we express blood flow, as sort of the amount of blood flowing through an organ, tissue, or blood in a given time. Right? So it's part of the cardiac output. It's similar to what I talked about in the earlier slides. And at rest, that total flow is fairly constant, and it's equal to the cardiac output, right? So we did this calculation already. So we took the average 75 beats per minute, and stroke volume was 70 mils per beat. We come out to a little over 5 liters per minute. And that would be our overall total blood flow. And then I showed you a slide where that can be divvied up. Okay, so something that would actually affect blood flow, all right, is something called peripheral resistance. So resistance is the opposition to flow. And so resistance has three main factors, which I've listed for here, is blood viscosity, vessel length, and vessel radius. So if the blood becomes more viscous, the resistance goes up because it's harder for the heart to actually move blood, okay? It becomes thicker, in other words. So it would go up with viscosity. Things that would affect that, red blood cells, albumin concentrations. Now these things don't change moment to moment, like the body doesn't adjust for resistance, by changing viscosity. That's more of a pathological thing. The vessel length. Our vessel lengths are fairly fixed, although they can change a little bit in certain cases. Overall, our vessel lengths are fairly fixed. However, the vessel length, the longer the vessel is, the more resistance there is, because as blood moves through a vessel, there's friction that's generated against the walls as it's flowing. The longer it is, the more cumulative friction you have. But that's still a fairly fixed feature of our bodies, and so that's not adjusted for to adjust the resistance. However, if I want to increase flow by decreasing the resistance, the only real way the body's going to be able to do that is not through viscosity, not through adjustment of vessel length, but it's going to do it through by changing the vessel radius. In other words, dilating, opening up a blood vessel, all right, or constricting. And so we call this vasoconstriction, is when a smooth muscle contracts in the vasculature, and when the smooth muscle relaxes, we call that vasodilation. Vasoconstriction, which again is going to be restricting that flow, what ends up happening is it decreases flow downstream. Vasodilation would increase the flow of blood downstream. And so organs are going to actually be able to manipulate that particular feature of vasodilation and vasoconstriction in order to increase or decrease the flow to that tissue. And that'll depend on, of course, its demand. Now, the flow is proportional to the radius raised to the fourth power. So this is actually a very powerful way to adjust for flow. So just as an example, flow is proportional to the radius raised to the fourth power. All right, it's proportional to the radius raised to the fourth power. So let's just take an example of that. Let's just say the flow was 1 ml per minute. All right, and that's proportional to the radius raised to the fourth power. Let's say the radius was 1 millimeter. 1 millimeter. All right, so that's the flow. If the radius was 1 millimeter, we'd have 1 mil per minute of flow going through that vessel. Now let's say I increase the radius to 3 millimeters. So I'm going to increase the radius by 3 millimeters. So now remember, that's raised to the fourth power. 3 raised to the fourth power is actually 81. So what that means is a proportional increase in flow. So you're getting an 81-fold increase, 81 mils per minute, 81-fold increase in your flow. All right, just by coming from 1 millimeter to 3 millimeters. And the same thing in reverse. If I was at 3 millimeters and I went to 1 millimeter, I'm going from 81 mils per minute down to 1 mil per minute. So this is a very effective way of adjusting flow. Now, in terms of resistance, the arterioles, so those are the arteries that come right before the capillaries, the arterioles are the most significant point of control for peripheral resistance. In fact, two-thirds of our total peripheral resistance, of all the resistance that's in our vasculature, actually comes from the arterioles. All right, they are the smallest of the arteries, but proportionally to their size, they have the most smooth muscle there, and they're very responsive, and they can actually constrict to a great degree, and it has a very large impact on the overall resistance of our systemic circulation. Meaning that if they were to constrict, that would increase resistance to flow. So when they constrict, it reduces flow into a capillary bed, because that's what's downstream of it. If they were to dilate, that would increase flow to a capillary bed. Okay, so that's why it's important to understand where they are positioned. All right, they outnumber any other type of artery, so that's the the most numerous points of control, and they're most muscular in proportion to that diameter, which is what I kind of just mentioned. Okay, and so they have a wide range in which they can change their radius. So now let's put this in context of our blood pressure. Now I've kind of alluded to this already in the earlier slides, but blood pressure is determined by physiologic factors of cardiac output and resistance. And in fact, this is the formula. Arterial blood pressure equals cardiac output times the total peripheral resistance. We've already talked about cardiac output. Cardiac output is influenced by heart rate and stroke volume. Now, cardiac output and the total peripheral resistance, all right, that's going to equal our arterial blood pressure. So in other words, if the cardiac output goes up and the resistance stays the same, the blood pressure goes up. If resistance goes up and cardiac output stays the same, the blood pressure goes up because they're directly proportional to it. So that's, if I rewrite it here so it's all on the same line, arterial blood pressure equals cardiac output times total peripheral resistance. This is a formula you guys have to know. So if either one of these parameters, cardiac output or total peripheral resistance, goes up or down, blood pressure goes in the same direction. Now they can go in reverse. Let's say I want to maintain blood pressure, okay? And let's say my resistance has gone up, so my blood pressure is going up. Well, if I want to maintain the blood pressure, then the cardiac output can come down. So they can actually go in opposite directions to help maintain a blood pressure. Okay, so they don't always have to work together in the same direction. Blood pressure is determined by physical factors as well. So it's determined by our cardiac output, our resistance, but physical factors that influence blood pressure are the volume of blood and the compliance of the blood vessels. So the compliance, again, is really essentially a measure of how distensible and how much pressure is generated every time a volume fills up the vessel. How much it can kind of stretch and kind of recoil with that volume. And when you're young, vessels are quite compliant. However, as we get older, a lot of that elastic tissue that makes them compliant is lost and replaced with collagen, which is not as compliant, and they become stiffer. And those stiffer vessels can actually cause blood pressure to rise. Blood volume can also play a role in that if blood volume goes down, your blood pressure goes down. If blood volume goes up, your blood pressure goes up. So these are physical factors that can affect blood pressure as well. Now that's going to be regulated by the kidneys, or the volume is going to be regulated by the kidneys. Okay, and there will be some interplay between these sort of physical factors that I'm talking about and the cardiac output and total peripheral resistance. So what I want to show you here is this: the formula for blood flow. This is important. So the flow of blood is equal to delta P over R. What this means is that blood flow is equal to a difference in pressure. Delta P means a difference in pressure over the resistance. So to interpret this simply means that is, let's say resistance goes up. If resistance goes up, then flow is going to go down. All right, that's what we said before. So the resistance resists flow. So it's as it goes up, flow goes down. Now, if on the other hand, I have a pressure difference. If I have a greater difference in my pressures, flow is going to go up. All right, so for example, a pressure difference could be on the arterial side 100 millimeters of mercury to the venous side, which is 0 millimeters of mercury, which is our fairly average pressure difference between arterial and venous side. That's our gradient, is pressure gradients from 100 millimeters of mercury to 0 millimeters of mercury. So since we have a gradient, blood will flow. So the delta P, there has to be a difference. Okay, if there's no difference in pressure, okay, then there is no flow. So the greater the difference, the greater the flow. Okay, now, so this is what we refer to as Ohm's law. All right, flow is equal to the difference in pressure over the resistance. Now, if I take this law of blood flow, okay, and I change this a little bit, and I say, all right, well, flow, as I mentioned before, is the same thing as saying cardiac output. It's a measure of volume over time. So I'm just going to substitute flow and just say cardiac output. And with delta P, I'm going to put that in context of our systemic circulation, the difference in pressure from the arterial side to the venous side. So I'm going to say, initially in the aorta, 120 over 80. If I take the average of that, let's just say it's about 100 millimeters of mercury on average. So 100 millimeters of mercury minus the venous side, which would be at the end of the venous system is like the right atrium, which is about 0. So that's the difference in pressure across the systemic circulation. All right, and so again, this is arterial side. So this is the arterial blood pressure, and this is the venous blood pressure. And then there is our resistance, and this is going to be the resistance of the entire systemic circulation. So I'm going to refer to that as the total peripheral resistance. That includes all the resistance, the viscosities and the blood vessel lengths and the constriction or dilation of the blood vessels. So we'll call that total peripheral resistance in the entire circulation. If I rearrange this, okay, well, first off, I have cardiac output equals aortic blood pressure. So 100 minus 0 is 100. So I'm just going to get rid of the venous blood pressure. So just put arterial blood pressure over total peripheral resistance. Then last, I'm just going to move this around, so I'm solving for arterial blood pressure. So I'm just going to change this to arterial blood pressure is equal to cardiac output times the total peripheral resistance. So in fact, what we start with is, which is common, which is Ohm's law. By substituting that in, I actually can derive the blood pressure equation that I just showed you on the previous slide. Okay, and you guys can take a look at this again, of course, and review this to see how I did that. But cardiac output represents our flow, the delta P from arterial side to venous side, right? And then finally the total peripheral resistance. So that's how we derive that equation. Okay, so now we know that blood pressure, all right, is influenced by the cardiac output, the resistance, the volume, as well as the compliance of the blood vessels. So the other way of looking at this pressure is actually, this is the force that's exerted against the vessel wall, the outward force, that pushing force that I referred to as hydrostatic force in earlier lectures. Okay, so because it pushes it, it creates a pulsation against in the arteries, right? That's that outward force, something that we can palpate, and we can also measure if we're actually measuring blood pressure. And so when we record blood pressure, we record it as systolic and diastolic, because remember, there's a peak pressure, which is the systolic. That's when the ventricles are contracting and ejecting volume into the arteries, and so therefore the pressure is higher. And in that case, we would refer to that as our systolic pressure. And under normal conditions, that's about 120. So that's the top number. And the bottom number would be the diastolic pressure, which is actually the lower pressure in the arterial system when the ventricles are relaxing or in diastole. And so the pressure is slowly coming down in the arterial system. And that usually drops to about 80 before the next ventricular contraction occurs. So that's, sort of our standard normal blood pressure is 120 over 80. Now, there's another useful measure, which is called the mean arterial pressure, which is used oftentimes in clinical situations, particularly in the ICU. And using it as a mean is very helpful because it helps to kind of bring various blood pressures together and to find out if the means are similar. Okay, so to calculate a mean, let's just go through that first. To calculate a mean, if you were to take a look at 120 over 80 and tell me what is the mean pressure, well, you could say, all right, well, 120 plus 80 divided by 2 should come out to about 100, right? So the mean should be, 100 millimeters of mercury. Now, that's not entirely accurate. The reason it's not entirely accurate is because in the cardiac cycle, the ventricle spends twice as much time in diastole than it does in systole. So it spends twice as much time at a lower pressure than it does at the higher pressure. And so that carries more weight in the average. And so, for example, the way we look at that instead is we'd say 120 plus 80 plus 80. Really, you say, plus 80 times 2. So plus 80 plus 80, because diastole is actually twice as long under resting conditions. It's twice as long than systole. So it's weighted a little bit more. So we add it again. Okay, so in that case, since diastole is twice as long than systole, we do 120 plus 80 times 2, divided by, well, now it's 3. So we have those 3 numbers now. And so divided by 3, that would come out to about 93 millimeters of mercury, which is less than the 100 actually. But this is a more accurate representation of the average pressure because we spend more time in diastole, which has a lower pressure. So yeah, so 93 millimeters of mercury. So we use that because it doesn't matter what the person's blood pressure is. We can take a mean arterial pressure, and we know what a good normal range is for that. So say anywhere from about 70 to about 95 or so millimeters of mercury is, again, a normal average range for mean arterial pressures. If it drops below 60, well, the mean pressure is too low now. It's too low. And what do I mean by too low? It means that this is representative of a perfusion pressure. Our blood pressure itself is a pressure that's adequate enough to perfuse our organs, to give them enough flow. If the mean arterial pressure is too low, okay, if it's too low, then it's not going to be enough adequate pressure to perfuse our organs appropriately, and the organs can actually suffer and then die. Okay, they could start to become what we call ischemic, and so that's a problem. So that's usually generally below, say, something like 60, mean arterial pressure of about 60 millimeters of mercury or so. Okay, and so that's that gives us an indication, and this is measurements that have been done in the clinic that help us let us know that, yeah, for people on average across the board, if you go below 60 millimeters of mercury, you're not going to perfuse your organs and they could start to suffer and die. So we want to bring that mean arterial pressure up, which is also useful because we don't want to have to go on an individual blood pressure by blood pressure basis and figure out if they're perfusing well enough. So we take this average, and the averages are very useful for that. Now, in terms of our blood flow, the blood cannot flow maximally to all organs at once. Remember, we only have a certain amount of blood that we have in our bodies, it's 5 liters. And so let's say, hypothetically, that all of our vessels were vasodilating together to maximize their blood flow. What would happen is we'd have a sharp drop in our pressure, right? Because again, arterial blood pressure is equal to that resistance. So if the resistance plummets, our blood pressure is also going to plummet. We're not going to be able to have enough pressure to perfuse all the organs adequately. And so in reality, what actually happens is blood flow shifts more to one organ than another based on how we're utilizing that organ. So in this example here, right, when you're at rest, this gentleman on the couch with his feet up drinking a beer, looks like, maybe watching football or something. His skeletal muscles are not really working right now. And so as an example here, let's say this is our abdominal aorta that you're seeing. All right, some of the branches there. So this is the branch, the superior mesenteric is one of the branches to the digestive system. And down here, the common iliacs would be going to his lower extremities, like his skeletal muscle. So his blood flow to his skeletal muscles in his lower extremities would be more constricted because the skeletal muscles don't require a whole lot of blood flow right now because they're not metabolizing a whole lot. Whereas his digestive system, looks like he's resting and digesting, it would increase flow to his gut. So he could, it could help with digestion. Now, over here, if they're playing soccer, you'd have the reverse of the situation. You would constrict flow to the digestive tract, and you would increase flow to the lower extremities in order to assist the skeletal muscle with the higher demand. And so this is how blood flow is shunted and how the body will actually regulate what gets more flow than another organ based on the need. So this pie chart is essentially showing the same thing, but it's showing you at rest, and it's giving you, multiple different body compartments to take a look at. So this is saying, all right, well, if the output is 5 liters per minute, all right, skeletal muscle takes about 20% even at rest, okay? Then you have digestive, 27%, 22% for renal, 14% for cerebral. This is actually something we saw in the earlier slides that I showed you guys, okay? So it's showing you how it's partitioned, what the demand is at rest. But let's say they do moderate exercise. Well, the cardiac output is going to increase to match the demand, right? So the cardiac output goes up. In this case, it went up to about 17.5 liters per minute. But look at the size of the chunk that now the muscles are getting. The skeletal muscles are getting 71.4% of that cardiac output compared to 20% at rest. All right, so this is a very large increase in volume to the skeletal muscle. Meanwhile, you get other compartments, okay, like renal, for example. Renal is actually much lower. It went to 3.4% overall. So its volume is greatly reduced. The digestive tract also reduced. So because we're constricting to those areas. Whereas the heart we're going to want to maintain because we want to increase that flow because it's a part of our ability to exercise. Okay, same thing with our brain. All right, so some areas will still continue their flow while others will increase and others may decrease. In terms of being able to regulate and being able to, the organs being able to say, well, I need more flow versus another one saying, I don't need as much. There are multiple ways in which that's actually regulated, okay? And so what we have are something called vasoreflexes, and these are quick and powerful ways of altering blood pressure and flow to meet whatever the demands are of particular parts of the body. So 3 ways of controlling the vasomotor activity, constriction or, relaxation, is local tissue control. So the organ itself, in other words. So the skeletal muscles, its metabolic demands have gone up. And so that skeletal muscle is actually influencing the blood flow directly. It's telling it to vasodilate, to increase flow to it, or to vasoconstrict. All right, so that would be the metabolic portion of this. And then there's the mechanical, all right, which we'll talk about. So this is what referred to as autoregulation. It's regulating itself. These organs are actually able to influence that flow. And they can actually influence their flow to the extent where they could increase their flow 20 times or more, or 20-fold. Neuronal control. That has to do with the sympathetic input, whether we're increasing or decreasing sympathetic output on our vessels to constrict or to dilate. And then hormonal control like epinephrine, angiotensin II, some of these hormones that we're going to talk about more. Okay, and so they can cause, for example, vasoconstriction. A decrease in epinephrine, a decrease in angiotensin II would cause vasodilation. So in terms of local flow, this is again the organ telling the vessels to increase or decrease the flow. Okay, so let's say, for example, we are increasing metabolites, so they're metabolizing more. So skeletal muscle is starting to metabolize more because you're exercising. This is going to cause vasodilation because we want more flow. We need to get rid of the waste that we're producing, the CO2, the lactic acid, and so on. We want to get rid of that. And we also need the oxygen and replenish the nutrients like glucose. And so we need to increase flow to do that. So in fact, CO2, lactic acid, low oxygen levels, these are all metabolites. Okay, and so what they can actually do is they can directly influence the precapillary sphincters on the arterial side to vasodilate. And when it does that, when it vasodilates, it's going to increase the flow into that capillary so that the tissue can then exchange more readily. So it can definitely increase that flow. Now, if the metabolites start to drop, then it has less influence on those sphincters, and so then that starts to close again. Mechanically speaking, we have something called a myogenic and a shear stress response. The myogenic, basically, if let's say I had a surge of volume, all right, that's going in towards the capillary. Well, the capillaries are fairly thin-walled, and I don't want a very large surge in volume to rupture my capillaries. So I want to protect them. So what ends up happening is, let's say I get a surge of volume that goes through the arterioles, and it causes them to distend, okay, transiently. That distension, in reaction to that distension, the arterioles, what they'll do is they'll constrict. They'll constrict, it'll constrict in order to reduce that expansion and prevent any volume overload into the capillary. And so that helps to reduce the risk of rupturing our capillaries. And this can happen with any type of surge in volume or pressure. You can vasoconstrict to prevent that. And this would be carried out by mechanical receptors like calcium receptors. So as it gets expanded, these mechanical calcium channels will open up just physically, and calcium can come in and it will cause it to vasoconstrict and then help to reduce that pressure surge. The shear stress response, this is friction between the blood vessel wall and the blood itself. We call it shear stress. This is rubbing on the vessel there. If the stress goes up, if there's more friction that's occurring, what can happen is that can trigger the endothelial cells to release nitric oxide, which causes the smooth muscle cells to relax. So if there's too much friction, which can damage the endothelial lining, it can actually cause a reaction to release nitric oxide and vasodilate so that the friction goes down. Now, the endothelium plays a very active role in helping to regulate locally our relaxation or constriction, our resistance. So it can influence relaxation of the smooth muscle by release of nitric oxide, like the shear stress response that I just mentioned. Prostacyclin, we talked about prostacyclin in the previous lecture as well. Prostacyclin can also locally influence smooth muscle relaxation. It also inhibits platelet aggregation, right? Contraction of the smooth muscle can be carried out by endothelins, or ET1, which can be released by the endothelium and influence contraction of the smooth muscle cells. So the endothelial cells themselves can appropriately respond to some of the stimulants. And over here, what you're seeing in the cartoon are just various pathways which you guys do not need to memorize, but just as examples. Here you see prostacyclin. All right, you see nitric oxide. These are some of the pathways that they could take. Ultimately, what they're doing is diffusing towards the smooth muscle. This is the smooth muscle cell right here. All right, and when it stimulates them, it causes relaxation. All right. In those examples, endothelin 1 it's not showing here, but endothelin 1 would cause the reverse, it would cause constriction. All right, so neural and hormonal can also regulate the blood pressure. And so the sympathetics, okay, they're the ones, there's no parasympathetic innervation. So the sympathetics carry out that moment-to-moment control, so they can increase or decrease contraction. So if there's more sympathetic stimulation, it's going to cause vasoconstriction. If there's less of it, it's going to cause vasodilation, so more relaxation. So that can increase or decrease flow. And the role of the sympathetics is they don't regulate organ flow. The metabolites do that. So what they'll do is they'll regulate more systemically. So this will help to make larger shifts of blood to help actually regulate the overall blood pressure. The endocrine, so hormonal regulations like epinephrine or angiotensin 2, epinephrine can either vasodilate or vasoconstrict. It just depends on the adrenergic receptor. So beta 2 adrenergic receptors, which are actually located on skeletal muscle blood vessels, that actually causes relaxation. So when we're exercising, that can actually increase blood flow to our skeletal muscle. Whereas alpha-1s actually cause primarily vasoconstriction, and that's mostly in abundance in most of our vasculature is alpha-1. So epinephrine would cause vasoconstriction there. Angiotensin 2, which is actually a hormone that's produced in what we call a renin pathway, which we'll get to in the kidney lecture. But the angiotensin 2, when those levels rise, actually causes vasoconstriction.